I would like to thank SAGES for inviting me to speak on this interesting topic. My only disclosure is serving as a consultant for AstraZeneca on an advisory board in the management of lung cancer. I'd like to start with a few case scenarios. Patient H is a 70-year-old, fairly spry Italian female who in October of 2014 was found on EGD to have an 8-centimeter segment of Barrett's. She had a nodular component that was removed by endoscopic mucosal resection, and the final pathology came back with a 12-millimeter focus of adenocarcinoma, pathologically staged at T1A. She had a follow-up scope a month later, and a 7-centimeter segment of Barrett's was once again noted. It was removed with EMR, and the path on that came back with no residual malignancy. Her next follow-up was in February of 2015, whereupon a 7-centimeter segment of Barrett's was noted. This was incompletely treated with radiofrequency ablation. She returned 2 months later, whereupon a 7-centimeter segment of Barrett's was once again noted and was retreated with RFA. In July of 2015, she had a repeat endoscopy, which demonstrated a 7-centimeter segment of Barrett's. This was treated with cryoablation. She returned in September for a repeat treatment, whereupon a 7-centimeter segment of Barrett's was once again noted. And in November 2015, she had a repeat endoscopy, which demonstrated a 6-centimeter segment of Barrett's, and this was treated with cryoablation. 2 days later, she presented to the emergency department with suspicion of an esophageal perforation, and this is when I met her. At that point, between the history of refractory Barrett's that was long segment and the esophageal perforation, I ended up doing an emergent transhiatal esophagectomy with reconstruction. She did well postoperatively. Patient G is a 71-year-old, more sedentary female who in September of 2017 was found to have a GE junction adenocarcinoma. This was treated with chemoradiation therapy, and the patient refused surgical resection. She was then followed with routine surveillance scans and EGDs, and in February of 2018, on EGD, she was noted to have a long segment of Barrett's with multiple foci of high-grade dysplasia, as high as 23 centimeters. I saw her as an outpatient and recommended a 3-incision esophagectomy. She did not have any postoperative complications, but her resection specimen had a small focus of adenocarcinoma staged at pathologic T1A, and it was distinct from the GE junction lesion. Unfortunately, she has since passed from metastatic cancer, presumably from the original GE junction adenocarcinoma. And patient D is a 69-year-old male who in June of 2017 was noted to have a focal mid-esophageal squamous cell carcinoma in situ. This was treated with EMR, and pathology came back as T1A. 3 months later, he had a repeat scope, which demonstrated a focal lower esophageal squamous cell carcinoma in situ, which also was treated with EMR, and the staging came back as T1A. In November 2017, he had an endoscopy, which demonstrated some Barrett's, and this was treated with cryoablation. He returned in March of 2018, whereupon more Barrett's was noted and was treated with cryoablation. Thereafter, he had routine surveillance and surveillance EGDs, which were unremarkable in June of 2018 and November 2018. So a year later, he returned for a surveillance EGD, whereupon a 2-centimeter segment of Barrett's was noted and some scarring. In March of 2020, he had a repeat endoscopy, which demonstrated a 14-centimeter segment of Barrett's. This was treated with radiofrequency ablation. 2 weeks after that, he presented to the emergency department with dysphagia. A scope demonstrated stenosis as tight as 7 millimeters in diameter. He underwent serial dilations and the placement of a stent. The stent was removed in May of 2020, and at this point, an esophageal mass was noted. He was biopsied and found to be positive for malignancy. He was staged at T3N1 and is currently undergoing induction chemoradiation treatment. And this is where I met him. These are the American College of Gastroenterology guidelines on the diagnosis and management of Barrett's. As you can see, endoscopic treatment seems to be first, second, and third line in the management of Barrett's. However, given the real-life clinical scenarios that I just described, this does beg the question of, are we being too aggressive with endoscopic treatment of Barrett's? The fact of the matter remains that endoscopic management of Barrett's is effective. In their multi-institutional randomized trial of 191 patients evaluating radiofrequency ablation for the management of Barrett's, which was published in the New England Journal of Medicine, Shaheen and colleagues demonstrated that in patients with a high-grade dysplasia, complete eradication was achieved in 81% of those treated, with 2% disease progression to malignancy. In a retrospective single-institution review published in Gastroenterology, Prasad et al. Compared patients with high-grade dysplasia who underwent photodynamic therapy versus esophagectomy. In this study of 199 patients, 129 patients underwent endoscopic management and 70 underwent an esophagectomy. High-grade dysplasia was eliminated in 88% of patients at 1 year and 86% at 3 years. And with a mean follow-up of 60 months in both groups, overall survival was similar between the groups. In 2013, the U.S. Multi-Center Consortium published their results of a multi-institutional database that included 529 patients treated endoscopically. 71% of the patients had high-grade dysplasia. 55% of patients underwent endoscopic mucosal resection and radiofrequency ablation. Complete eradication of Barrett's was seen in 56% of patients at 2 years, and recurrence of patients with esophageal cancer was only seen in 1 patient. Another important fact is that endoscopic therapies have decreased morbidity than esophagectomy. In a meta-analysis including 870 patients comparing endoscopic eradication therapies to surgery for early neoplasia in Barrett's esophagus, Wu and colleagues demonstrated that the endoscopic group had significantly less severe adverse events without a significant difference in remission rate, neoplasia-related mortality, or overall survival at 1, 3, and 5 years. And published very recently by the group at the University of Michigan was a quality of life study following endoscopic treatment versus esophagectomy. Validated quality of life questionnaires were mailed to patients who were treated between 2000 and 2016. 91 patients who were treated endoscopically and 62 patients who were treated surgically responded. With regards to symptoms, patients treated endoscopically reported better scores with respect to diarrhea, eating difficulty, choking, coughing, and difficulty with speech. On the other hand, arguments in support of early esophagectomy include the risk of undiagnosed or unrecognized malignancy or recurrence and progression of disease. In the same study published in Gastroenterology that I mentioned in the previous slide, in the surgery group, 9 of the 70 patients had carcinoma in the resected specimen despite pre-op surveillance. 4 of these were intramucosal only and 5 were submucosal. Older studies have documented rates of adenocarcinoma in patients with high-grade dysplasia as high as 75%. But more recent studies report a rate of occult adenocarcinoma in patients with Barrett's of 42%. Of these, 73% had T1 disease, while 15 and 10% had T2 and T3 disease. Additionally, there is a higher rate of recurrence and progression with endoscopic management. In the gastroenterology paper of the patients in the photodynamic therapy group, 8 patients developed carcinoma. Also, in a small cohort study comparing endoscopic management versus esophagectomy for high-grade dysplasia, the recurrence rate was 5.6% for endoscopy, but 2.6% for esophagectomy. Now, proponents of endoscopic treatment often cite the high risk of esophagectomies as a deterrent for esophagectomy and the treatment of Barrett's. With high volume centers and minimally invasive esophagectomies, more recent mortality rates are improved. In the Eastern Cooperative Oncology Group study, ICU length of stay and mean hospital length of stay were reported as 2 and 9 days respectively. Anastomotic leak rates and postoperative pneumonia rates were 7.8% and 4.9%, and 30-day mortality was 2%. Never mind the fact that esophagectomies performed in high-grade dysplasia patients are typically in healthier patients and require less extensive dissection, and therefore outcomes typically tend to be better. Finally, critical to the success of endoscopic management of Barrett's is regular follow-up. A recent paper published out of Scandinavia demonstrated that deviation from endoscopic treatment guidelines was as high as 60%. To be fair, deviation from guidelines in patients with high-grade dysplasia was a little bit lower at 39%, but one of the risk factors for deviation from guidelines was longer segment Barrett's, which is a scenario that usually warrants early evaluation for esophagectomy. So there are limitations to endoscopic therapy, and these include patient noncompliance. Ablative therapy typically requires multiple treatments, and surveillance is paramount to assure complete eradication. This cannot be achieved with a patient who is non-compliant to the treatment and surveillance regimen. A history of prior radiation is a relative contraindication due to poor tissue contact, poor healing, and increased risk of stricture formation. The presence of esophageal varices also is a relative contraindication due to delayed bleeding after mucosal necrosis. Endoscopic mucosal resection of more than 50% of the circumference should be avoided on account of stricture formation. And finally, recurrent or refractory disease and long segment Barrett's are less likely to be treated successfully with endoscopic modalities. Well, the buck stops here. Esophagectomy is usually a measure of last resort in the management of Barrett's, such as clinical scenarios with a higher chances of endoscopic failure. These include patients with multifocal high-grade dysplasia and an inability to resect the Barrett segment en bloc, in patients with long segments of Barrett's, and in patients with a history of previously failed endoscopic therapy. Esophagectomy is also preferred in patients with an otherwise diseased esophagus, such as an end-stage esophageal disease like a refractory stricture or motility disorder. Esophagectomy may be indicated in patients who are unable, for one reason or another, to comply with a repeated treatment and surveillance regimen of endoscopic treatment. And of course, we cannot forget about patient preference. Sometimes patients simply do not want the anxiety or concern of progression to malignancy, although with established good results and outcomes with endoscopic resection for high-grade dysplasia and T1A malignancies, this sentiment is becoming more and more rare among patients. There are some technical points to keep in mind when performing an esophagectomy for Barrett's. It is crucial to remove all of the Barrett's mucosa, which usually involves a high resection with a neck anastomosis, so esophagectomy via a transhiatal or 3-incision approach is preferred. Bear in mind that the key is to minimize morbidity and that patients undergoing minimally invasive esophagectomy fare better. They have a faster recovery, fewer pulmonary complications, decreased ICU, and overall hospital length of stay. And lastly, outcomes are better at high volume centers. And by that I mean when the surgery is being performed by an experienced surgeon with specialty training and in a setting with excellent critical care support. So, in going back to the patients I presented earlier, should we have intervened sooner from a surgical perspective? Patient H was a patient who had a small focus of adenocarcinoma that was successfully treated with EMR but had refractory long segment Barrett's despite numerous treatments, who ultimately perforated following cryoablation. I would say probably this patient should have been introduced to surgery sooner. Certainly an elective esophagectomy is preferred over an emergent one on account of the poor outcomes of emergent cases. Fortunately, once again, this patient did well. Patient G is a patient who had a G junction cancer treated with chemoradiation and a long segment of Barrett's with high-grade dysplasia on surveillance. From the standpoint of her G junction adenocarcinoma, I would say we should have operated or have been involved sooner, but she refused. From the standpoint of her long segment Barrett's with multifocal high-grade dysplasia, we were involved and intervened as soon as we were made aware of the situation. Lastly, patient D is a patient who had squamous cell carcinoma in situ and 2.5 years of surveillance and endoscopic treatment, now with T3N1 esophageal cancer. This one's a little bit more controversial with regards to the progression of esophageal cancer. However, probably a 14 centimeter segment of Barrett should not be treated with radiofrequency ablation. I think we all can agree that 14 centimeters qualifies as a long segment of Barrett's. So the last thought that I leave you with is that these decisions are complex. There is no one right answer. Discussing and managing these patients in a multidisciplinary fashion with the involvement of both gastroenterology and surgery, and not just involving surgery when the patient is perforated or has a malignancy, is paramount to the success of the management of these patients. Thank you for your attention.